Or she turned it off. Tricky. Okay, yeah, so these are the people who did a lot of the work. So what is cancer cachexia? Cachexia is a condition that is experienced by many late stage cancer patients where they lose a lot of fat and muscle tissue and then become very weak, tired. They don't want to eat. They feel very ill, and it can lead to mortality up to 80% in these cancer patients. In particular, most pancreatic cancer patients will have cachexia. Some prostate and colon cancers, breast and leukemia patients will experience this. It contributes to an extreme decrease in the quality of life for these patients where they don't want to get out of bed, they don't want to do anything. And it can lead to the termination of their treatments, which of course is not what we want to do. Also, to add to this, chemotherapy can itself cause cachexia, so it can make the problem worse. So in this talk, I'm going to highlight two papers that we did, one focusing on cancer-induced cachexia, and then chemotherapy-induced cachexia, and then sort of future work is how do we treat cachectic cancer patients with sort of palliative chemotherapy, because at that point, curative treatment is not possible. Okay. So we're going to start with a model of the muscle, because we focus on the muscle because muscle, gives us energy and stuff. So we want to preserve the muscle so that patients feel good. So we have the stem cell, a simple stem cell model where we have stem cells that differentiate symmetrically, either self-renewal this way or complete differentiation this way. We ignore the asymmetric division. And so we put that into the simple kind of ODEs like this, where we have probability of self-renewal. And then we need to add some feedback mechanisms here so that the muscle mass, in this case, we have mouse data, so the mice grow to their adult sizes and then stop growing. So here is the parameterization. We took, the growth curve for the mice and then extended it so that we had better fitting. So that's for the mouse. So the mouse will grow to its adult size and then stay that for as long as we want to simulate. Then we want to consider what kind of signaling is happening from the tumor that is causing the muscle to start wasting away. And through studying the pathways, etc., we discovered that its actions are really targeting the differentiation process. So we inserted these sort of the tumor is disrupting the muscle somehow. It's causing disruption to the proliferation rate and the differentiation process here. And it can also directly cause death through, forget what the word is, but when it causes the death of the cell. Sorry, forgetting my words. So then we fit the tumor growth rate, exponential linear growth, and we fit these model parameters to the mouse data to determine all the parameter values. And then we looked at the treatment. So the first case here is when, well, actually, the black curve is the normal mice, and then the red curve is the cachectic mice. So they're losing their muscle. This is lean mass. It's measured, like put the mouse on a scale. So they're losing their weight. That's the red curve. And then in the paper we were looking at, they had a novel anti-activin A treatment that was supposed to block the pathway that was causing the breakdown of the muscle fibers. So that the A's here are all the action of that treatment that was injected. And that's the green curve. So we were able to also fit that. And they had an early and a late curve. We fit to the early data very well, but then the late data wasn't as great a fit. So that's the cancer is inducing muscle loss model. Then we looked at chemotherapy. So we specifically looked at 5-FU, which is a common chemo drug for certain types of cancer. And it has a really interesting profile in terms of how it causes body weight loss in these mice. in that it's not linear with the dose. I fit it to a cubic, basically, to the drug concentration. Oops, where are we going? So that you see this interesting spread here in the curve. So the black curve is 0 dose delivered daily, and the blue one at the bottom is 35 milligrams delivered daily. And there's this spreading out of the curve. So up until 20 milligrams per kilogram, that's the orange curve, there's essentially no weight loss. But then after that, you see an extreme drop. And on this side, they explored 5 days on, 2 days off. So the standard sort of, we don't treat on holiday on the weekend type of treatment strategy. And there you see that you can sustain a larger dose without losing weight. So we added a 2-compartment PK model, so necessarily so that we could talk about what is the concentration in the muscle, not just in the blood compartment. So then we tried to fit just the standard things like the simplest Heiko's razors things, where we would be fitting the simplest model to that data, but nothing would fit. And then we tried, well, what if it's, not just proportional to dose, it's proportional to the dose squared or the dose cubed? Nothing worked. And then we got the idea, well, what if we actually, it's not just the dose that we're experiencing immediately, but it's our exposure. Like we've been sitting in this soup of chemo for a while. So we have this exposure model that we introduced where we're sort of time averaging over a sliding window and say, in the past tau days, how much drug was I exposed to? And then that is proportional to how the muscle cells would die. So that's what this Y function is here, which we put in here because it disrupts both proliferation and differentiation. And it's cubed, again, because I have to explain the spread in the response of the dose. And that fixed very nicely, actually. So we fit it to the daily model here and the 5 days on, 2 days off treatment strategy here. And that's our complete model on the right for chemotherapy-induced muscle loss. So with both of those things, I kind of skipped all the simulations because it was only a 12-minute talk, which some other people forgot. Right, so I skipped the simulations, but basically the simulations show what we would expect. You cannot treat effectively the tumor without causing muscle loss if the drug is going to cause the muscle loss. So they were very dichotomous outcomes. If you want to preserve the mass, you can't effectively give the drug, and the forms of the drug push you towards maximum tolerated dose. So any kind of metronomic dosing with the standard like log kill models doesn't work. If you're interested in the bias that the log kill model imposes in such simulations, that I would encourage you to see Chenyan's poster on Thursday, which is talking specifically about bias in treatment. That's a shameless plug. But then we put the two models together. So now we have chemotherapy-induced cachexia and cancer-induced cachexia. And I found another data set that is completely a new group from what the previous data sets we were fitting to. And so we have actually a surprisingly good fit, given that we didn't fit to any of this data. So this is the control mice. The blue is, the light blue, sorry, is the cancer-induced cachexia. That's the light blue. And the dark blue is cancer cachexia with 5-FU treatment. And so, yeah, so the dashed lines are our model and the dots are the data set. So now with this, this is ongoing work now to try to say with the full model, how can we best treat these patients? And so I threw in one slide of simulations, but that's where we're at right now. And so the takeaway message is really from the simulations I did not show you, that our lean mass is best preserved by intervening as soon as possible and giving an anti-cachexia treatment if possible. That was just in mice data that we were looking at. The tumor control, of course, is achieved by maximum tolerated doses even if you have the dose holidays in, that's kind of baked into the log kill model that we assumed. And the schedules that will best control your tumor are going to be worse for your muscle. And so for the patient. And that is all I have to say. Thank you very much. This is to the funding. And I just wanted to point out that this is a picture of Toronto. We are here. This was taken from St. Catharines, which is near Niagara Falls, where some of you might go. This was during the eclipse, the total eclipse. So I'm standing under the total eclipse, and Toronto was only partial eclipse. So that's why it's lit up there and it kind of looks like a sunset. But anyways, we're here. Thank you for coming to Toronto.